about drug therapy as well. I do have some information on evidence-based practice of drug therapy in COVID. So it's well known how the pandemic, as the definition says, has affected the whole world. But we can take some solace from the fact that India is not as badly affected as elsewhere in the world, as in the Far East or Europe or the United States, where the impact of the pandemic has been a lot more severe. Particularly if you look at the deaths compared to the population as a ratio of the population, we are very fortunate that the pandemic has not been too bad. That's something we can take some comfort in. But the problem that we have in this country, and it is so elsewhere in the world as well, it is not unique to this country, is the reaction of all the stakeholders, all segments of society who are dealing with this very difficult situation are in a state of panic. And there is a huge clash between fact, which is science, and belief, which is basically emotion. So there has to be a balance, and until and unless we give a great predominance to fact and science and completely suppress belief, emotions, and myths, as Dr. Sudha was saying, unless we suppress myths and belief, we really can't have good success in facing this pandemic. What are the scientific facts that we should be aware of? While the disease is dangerous, you must understand that it is not terribly fatal. People don't die of it the way you generally imagine it to be. In fact, 40% have no symptoms. They may have an infection, but nobody will know that they have the infection. The large majority have a mild flu-like disease, and some people will have a little bit more difficulty in terms of breathing, breathlessness, fall in oxygen levels, cough, and things like that. It's usually a dry cough, and that's a relatively small percentage. But the number of people who actually die of the disease is extremely small. But you look at the papers every morning, it's the deaths that are highlighted. I'm not saying there are no deaths, and even a small percentage of a large population like ours would be large numbers. I agree with that. But the fact remains that it is a very small percentage, and so the large majority of the population can take comfort from the fact that what is called the case fatality rate, the number of people dying because of COVID, is indeed small. It is a little high for people who are over 60 and who have what we call comorbidities like diabetes, hypertension, heart disease, lung disease. If you have pre-existing problems before the COVID days, yes, the mortality is a little higher. Maybe 10% is a more realistic value. But please understand, even that is not a huge number. Dr. Sudha talked about evidence-based medicine, and I couldn't agree with her more. If you have a scientific outlook, you have to have proof or evidence that a given medicine works. I'll spend 2 minutes on this graphic. All drugs, before they reach the treatment, undergo what is called an FDA review. FDA is the Food and Drug Administration in America. India has its own drug controller, and they go through a similar process. Phase 1 is basically done in healthy volunteers to say that the drug does not cause any great harm to them. So healthy volunteers without disease have phase 1. Phase 2 is the next phase where a small number of patients are tested, maybe 100, maybe 200, 300 maybe. They're given the medicine, and it is designed to make sure that the medicine has some effectivity and to determine the dosage, basically, to make sure what the optimal dosage is. So that does not prove that the medicine really works. So you need to have a completed phase 3 trial where a large number of people participate and the medicine is proven to work with minimal or no side effects. Minimal is a more realistic expectation. So when that is done, then they apply for permission to be given to the population, and then it is used. Now I'm going to give you some slides in this, some graphics in the subsequent slides where I can show you that a lot of medicines that are being used, that are being talked about, are only in phase 2. We really haven't had phase 3 completed trials. And when phase 3 completed trials are really looked at, and I'm going to show you that, very few things are going to prove to us that it actually works, very few medicines. And it is very important because right now, what is pushed around is a lot of things which are what I can call untested. And one of the common reasons for using this is the emotional and the social pressure that is brought about on the healthcare system. Patients want something, they want an intervention. They can't, how can you not give us something when we are facing a dire situation? And so to perhaps meet the emotional needs of people, doctors and hospitals perhaps meet that requirement. And it would be incorrect to say that it is pushed only for commercial reasons. There may be a minority who would push it for commercial reasons. I'm not gainsaying that. But a lot of it is because people want something done even when it doesn't work. So the next few slides may be a little overwhelming for people who are not used to medical data. But let me try and help you, and don't try to understand everything in perfection. Just get the trend of what I'm trying to say. Medicines that can be given for COVID fall under two groups: the so-called antiviral drugs and the so-called immune system treatments. These are the two broad classifications that can be used. And hydroxychloroquine is one of the drugs that are pushed for this. What you must understand in this perhaps confusing graphic is that the black line is no medication, the red line is medication. In this slide, the medication is hydroxychloroquine. The larger the distance between these two, please note, the black line should be far away from the red line. Only then you know that the medicine works. So you can see that in this slide, the two lines are very close. This is death at the end of 28 days. So they are very true, very close, and which means that hydroxychloroquine, which is pushed a lot, doesn't work. Please note that I have taken all these slides from a Royal College webinar which was held last week. The information is as current as can be. All right. So if you are looking at the other big drug, remdesivir, it's called, and as Dr. Sudha mentioned, it costs anywhere between 5,000 and 7,000 rupees per injection, and the total cost of the treatment is about 40,000 rupees. Understand that even here it is the blue line rather than the black line. The two lines are very, very close. But what it shows is that while the death rate is not in any way impacted when the two are the same, whether you give remdesivir or not, the number of days spent in the hospital or in the ICU is shortened by 4 days. If you did not get remdesivir, you will perhaps on an average stay 15 days. But if you did take remdesivir, you would perhaps stay 11 days. Now, it is for the patient to decide whether this little improvement deserves the kind of expenditure that it entails or not. It is as simple as that. But it must be made clear to the patient that as far as the risk to life is concerned, there is no difference even when you take remdesivir. And this is something which you have to understand. Dexamethasone is a steroid, and actually it is the only drug which shows a big difference between the red line and the black line. If you see, if somebody is on a ventilator, if somebody is in an ICU, ill with COVID, if you give them dexamethasone, then it reduces the death rate by 30% in the severely ill ventilated patients, and it reduces it by about 20% in the less ill but still ill. They are not on a ventilator, but they are oxygen dependent. Such patients, the mortality rate is reduced. So to date, through scientific methods called randomized controlled trials that we mentioned a bit earlier, it is this drug and this drug alone that is known to work. But the world over, lots of drugs, it's not just the story in India, across the world, everything and anything is being tried because people are desperate, people are in a panic. And so if you're really scientific minded, for example, personally, I have myself said to my family, and I've written it down in my what's called an advance directive, that if I ever have to go to get treatment for COVID, I would not want anything other than dexamethasone to be given to me. I've actually put it in writing. That is the kind of conviction I have in the studies that have been declared so far. It's also true that newer and newer studies are coming every week, and as and when new information comes, we should be aware of that new information, and if it is scientifically proven, we have to transfer it on for the welfare of our patients. So in summary, ladies and gentlemen, all I can say is that in dexamethasone is the only drug that is used, that is shown to be of use. One thing that is not mentioned in the slide is the use of anticoagulants. It's been now, recent information has come out that clotting in small blood vessels is one of the primary pathologies or problems with COVID. And so if you give them a medication that reduces the clotting capacity, and that does help them as far as oxygenation is concerned. As you know, lack of oxygen is the primary problem in COVID pneumonia. Now, as I said, remdesivir can be used with the rider that it has no real effect on mortality but reduces hospitalization, and dexamethasone does help with the mortality. And if you see even in the lay press, I can see one whiff of fresh air. You know what I call WhatsApp University, hundreds and thousands of messages going on in WhatsApp, lots of things coming in our papers. None of them honestly tell you the truth. But here, Dr. Zarir Udwadia, who is a chest physician from Bombay, writing in TOI about 3 days ago, said this, and I think what he said, he hit the nail on the head. He said, it is, however, said that physicians in India have always felt compelled to prescribe medications to their patients because patients expect it. This is a self-fulfilling prophecy. As with other bad habits during the pandemic, now is a good time to break it once and for all. What is trying to give a heads up to society, to patients, to social activists, to doctors, to the healthcare, everything, is to say, please don't go by emotions, don't expect things which are unreasonable, don't demand things which are unscientific. And for the doctors to say, please don't prescribe things which are unscientific. But please understand from a doctor's point of view, which I'm trying to place before all of you, even if I tell somebody, look, ventilation is not going to help you. It is known that when a stage comes in COVID, when you need ventilation, when high flow oxygen and so-called CPAP, or there are various methods that people can use, what is called non-invasive ventilation and proning. These are 4 things that doctors use. When none of this really works, if you have to put a patient on a ventilator, hardly anybody comes out of a ventilator. You can see the amount of, what shall I say, turmoil that's going on because we don't have enough ventilators in this country. We have to understand that even if there are millions of free ventilators, if you put every single patient on a ventilator, you're going to help less than 2 to 3% of these people. On a ventilator with the best available kind of support in COVID pneumonia, in a person needing ventilation, not more than 5% at the most, it's more like 2% or 3%. Survive. 95% are not going to survive. I mean, so that is a reality that all of us, the healthcare system, the people, the society at large, all of us have to realize. And it is extremely important that we realize that. Otherwise, this big scramble for the number of ventilators is something I do not understand. And so, when a healthcare facility tells you that they cannot give you ventilators, but they can look after you with oxygen and its modifications in a ward, I would recommend that an average person comes to terms with it, agrees with it, and gets an admission. What is happening is that because people don't have ventilatory beds, do not have ICU beds, even this help or support with oxygen in a ward is not being given because patients want guarantees that they will get a ventilator if it is required. Such a guarantee, no healthcare facility can give you. This is about medication and the support care for COVID. Now I get into the phase where, as a surgeon, it impacts my practice as a surgeon, and it impacts the patients who need surgery during COVID periods. Dr. Sudha mentioned many issues, one of which, of course, is non-COVID disease in the face of COVID pandemic. We must understand that COVID is going to be around for several months more. It's not going to just disappear. And so people do get a lot of surgical problems. They do have babies. They will have gynecological problems, orthopedic problems, accidents take place. A wide variety of surgical procedures will have to be done. And so I'm going to give some information about how surgeons face this challenge of doing surgery in the time of the COVID pandemic. This graphic tells you the spread of the disease. It is a respiratory disease, sits in the oral and nasal passages and in the airways. And when you're standing and talking and breathing, the virus perhaps goes about 3 feet. And if you're coughing a little bit and breathing hard or exhaling hard, it will probably go 6 feet. And that's why we ask that you keep a distance of 6 feet from anybody else that you come in contact with. Please note, this is when you're not wearing a mask. When you're wearing a mask, it is much less. And particularly when you sneeze, when there is a forceful exit of air from your nasal or oral passages, you can go a long distance, 20 feet you can go. And that is drastically reduced when you sneeze. And so the recommendation is that you must wear a mask all the time. When you do cough or sneeze, cough into your sleeve, onto your arm there, onto your cloth there. Do not cough out in the open, and do not keep your bare hand on your mouth. Use a tissue and throw it away after you cough. If you ever put a bare hand onto your mouth or nose or something, please immediately wash your hands. That is the standard thing, and this is a highly scientifically established fact. There are many labs which have given out this data. This is from the MIT lab, Massachusetts Institute of Technology, from Boston. So the only proven methods for avoiding COVID are these: masks, distancing of 6 feet, isolation of hands. And when you know that you're isolated, if you have the capacity, have a separate room in your house, go and stay in that room. Nobody else will get in or get out of that room, however demeaning perhaps or emotionally disturbing perhaps it is. Your food will be left outside for you. It will not be given in your hands. You open the door, pick up the food, take it back into your room, close the door, eat your food, put the empty plates outside, close the door, and somebody else will come and take your plates and go out and wash it. It is not fomite driven, which means virus is not going to sit very much on handles, door handles and plates and clothes that we use. I know that people are worried about this and they keep washing everything. The survival of virus on handles and things like that, what are called fomites, is usually not more than 6 hours. But if you have gloves on when you take things from people who are COVID positive, and after you take the things and put it somewhere and discard the gloves, it is very unlikely that the disease or the virus will be transmitted to you. Coming to the specific aspect of what a surgeon does when a patient is COVID positive or is of an unknown status, when the COVID is in the community, for example, like it is in Bangalore today or in the country today. When somebody comes to you with a disease into the hospital, you don't know whether they're COVID positive or not. And so we presume that everybody is COVID positive until otherwise, and take precautions to meet that situation. So from the patient's point of view, for which the surgeon is primarily responsible, we need to look at surgical risks. Is there increased risks if a patient is COVID positive? Suppose a patient comes with hernia. Now, if I do hernia when in a COVID negative patient, and if I do it in a COVID positive patient, is there a difference in outcome? That is what is called risks of surgery in the face of COVID. What are the risks to the family? Now, what are the emotional issues? Surgery is an invasive specialty. So it's always an emotive subject when somebody comes, and we understand that very well. How do we deal with the emotional issues of the patient? How do we support the family? These are the things that we have to give extra care about in the face of the pandemic. And surgeon is the chief of a team. Now, he is responsible for the safety of the team. What happens to the team? Safety of medical personnel, the nursing staff, a lot of support staff, and the health of the hospital. What do I mean by that? Will the system take the extra precautions that are needed? Will it be able to manage the finances that are needed? Please understand, while I completely take the point that there are occasional reports of private medical establishments fleecing the patient, by and large, there is a huge escalation in the cost of treating a patient in the face of the pandemic. I will be touching upon this. And so it is a responsibility of a consultant or a surgeon of an institution to look at that aspect also, particularly when the government system is not able to manage it, when the private system has to bear the costs and the administrative load, extra load that this kind of a pandemic brings. We need to think of those implications as well. And so to keep a hospital ready for such an eventuality, which we have all done, and I'm going to share that with you, we need to have a good, robust screening method first. So when you allow somebody in, you allow only the patients in. Don't allow the whole retinue of their friends in, because the more number of people who come into the hospital, higher the chances of them bringing COVID in. It affects everybody in the hospital. So once the limited number of people come into the hospital, you don't know whether they're COVID positive or negative. So you may have to test them for it if they have certain symptoms which suggest that they may have holding and they may have COVID. And once you know what their system is, whether they're positive or negative, then there must be a separation of the stream. COVID positive patients cannot be mixed with COVID negative patients. So there must be a separation. So these are the things that one bears in mind. And to make it possible, I've mentioned about the entry restrictions. I'll show you some of the things that we have done in our own institution about holding. And we have COVID positive and COVID negative people in separate floors. There is absolutely no admixing of personnel, patients, or materials between these two floors. And it's even better if a hospital is big enough to have two wings. If they have two wings, one can be a COVID wing, another one can be a non-COVID wing. So this is the readiness. When you walk into a hospital, there is a person with protection equipment on who checks your temperature and gives you a hand sanitizer. If the temperature is high, you're not allowed in. If you're a visitor, and actually all visitors, even if their temperatures are normal, are generally highly discouraged, but they're allowed in if they have to accompany a person who cannot be by himself. But if you are a patient, you go through a different route, and you do not go through the normal route that people take. And everybody else who is negative here, doesn't have a temperature and who has had a hand sanitized, will go and be met by a nurse right adjacent to this area, who will take a history, talks about possible exposure to COVID, your temperature, cough, breathlessness, and things like that. And if you have any of those positive, you again go into the separate holding area. If all of them are negative, you come into the main area. And that's how we screen people coming into the hospital. It does mean inconvenience to the patient, but I'm trying to tell you the science behind that inconvenience. It is known that if you operate on a patient who is COVID positive, the risks of surgery are 5 to 10 times higher. So if the patients have any signs of COVID, or if they're, and that's why we test all patients for COVID, if they are COVID positive, if the surgery can be postponed, we never do the surgery. We ask them to come back after 3 or 4 weeks and then do the same thing. But there are emergency situations where surgery has to be done. If it has to be done, there are temporizing measures, not a full-scale surgery. These measures will be inadequate in terms of totality of care, but it will be adequate in terms of relieving pain. For example, if somebody has an abscess, we would probably normally take them to an operation theater, give them anesthesia, and drain it very nicely. But if they are COVID positive, we take them to the minor OT without admission, make a little nick, let the pus out, and the pus coming out will continue to fester for a bit, but at least the pain is relieved. They can sleep with comfort. So we use temporizing measures to relieve the pain and ask them to come back later. But there are some situations where they have to have operation, otherwise their life may be in danger. Such surgical conditions only we go and operate if they are COVID positive. There are limitations in testing as well. Sorry about this little formatting problem because of the different system I'm using here. And please understand that there are issues with our testing itself. There is a concept of false negative and false positive. I would like to tell you that the standard agreed world gold standard is what is called RT-PCR. There is another one that's available now called antigen. Antigen is much faster than RT-PCR. Generally, we get RT-PCR in about 24 hours now. But it has a false negative rate of 20%. What does it mean? When somebody is COVID positive, the PCR test will tell you that they are negative. Shocking, but true. But that is the best we have. False positive is even more galling, even more disturbing to a person who doesn't understand that. False positive means that when somebody is COVID negative, he doesn't have COVID, but the test says that he has COVID. Look at the emotional impact on the person and the family. He will be put into an isolation, maybe into an isolation ward. We may deny him an operation that he needs because he is falsely said. But ladies and gentlemen, that is the best we have today. Anywhere in the world, it's not an Indian condition. Anywhere in the world, you have a false negative and a false positive rate. For the antigen, the false negative rate is even more. It may be 30 or 40%. There is no solid data about the false positivity, but that will probably be the same as in RT-PCR, even though we don't have solid data about it. So please understand that when I have seen reports in the paper as well saying that such bad reports were given by certain labs. Any lab anywhere in the world can be caught out on this. The other important patient concern is emotional and family issues. This is where I would really appeal to all non-doctors to bear this in mind. We cannot talk to you in person. We cannot have two people who are, we understand that that kind of communication is very important to comfort the people. But more and more people coming and standing there increase the chances of healthcare facility personnel, doctors and nurses getting COVID. And if all of us, doctors and nurses, go away, get COVID and go away for a 14-day quarantine, there will be no doctors left to treat people, no nurses left to treat people. So it's important that we protect our police, our BBMP workers, we protect our doctors and nurses. And to that extent, we need our public to understand that more and more people should not be coming into hospitals. All counseling and all kind of communication will occur on phones and WhatsApp situations. And when somebody is ill, I can understand how distressing it is to a family member not to be next to the patient. But you can't be, because you can't walk in and out of a hospital having visited a COVID positive patient with illness, with pneumonia. The only way possible is that you also stay in the hospital with the patient all the time. And that is not practically possible. So visiting is very, very difficult. And one of the most distressing things is when somebody is lost, when somebody is dead, sometimes there are big issues even in the way, even during cremation or burial or whatever the case may be. Family people cannot go and grieve and do the normal things that we do. But the unfortunate situation is that this pandemic has turned our lives upside down, and people need to understand. And finally, the financial issues. The government put out a notice some time ago that it costs about 3 lakhs to treat a patient with COVID in the government setup. True, the patient is not paying for it. But how many people can the government look after? But the same 3 lakhs will be spent in the private setup also. Somebody has to pay for it. Either the insurance or the government, when neither of them do it, it will have to be the patient from out of pocket. We understand that costs are high, but why are the costs so high? Please understand that to protect healthcare personnel, we normally throw away at least 10 to 15,000 worth of what is called personal protection equipment. The sheets, the pillow covers, the gowns that we wear, the masks, the gloves that we wear. 4 or 5 people walking in and out of the patient's room or ICUs. The disposable burden is huge. And when you keep all the patients the families or the staff people don't go home and come back. They do a week together. They're in the hospital with the patients. You pay them, you make arrangements for their stay elsewhere, give them food, look after them well. All these things puts a huge burden on the hospital to meet. And so that is the reason for the cost of a patient care. Just to go into the nitty-gritty, I will take another 5 minutes and finish my presentation. This is the basic protection that we have. This is what's called an N95 mask and a visor. And we never wear our clothes when we go into the hospital. As soon as we go into the hospital, we get into our changing area and wear our what is called greens, the OT treatment. Earlier, we used to wear it only in the OT. Now we wear it all over the hospital. In the intermediate stage, we wear a gown and we'll have gloves all the time covering all of us. And all these things are thrown away once they are worn. And in a full protection, look at the way this is me in my outpatient department. This is the way I greet my patients. Very distressing for me as well. But that is a choice. This is my patient. I don't know whether it's COVID positive or negative. So I'm completely having a full PPE, and every bit of it is thrown away after I finish my outpatients for an hour. And endoscopy is a high risk procedure. So we do endoscopy also with that kind of a full protection. The person doing it has that protection, and our nurses who are far away from the patient looking the other way, they also have the same degree of protection. And surgery is even worse. As I told you, in a COVID positive patient, we try to avoid surgery as much as possible. But if it is not possible, the whole team, not just one person, has to wear even a bigger mask than the N95 called a respirator. So these are special filters which protect you from inhaling the virus. And we have over all this, you have these several layers of protection with a hood, and we then operate to protect ourselves. And earlier there used to be a lot of reservation about doing laparoscopy or using certain standard equipment like cautery. Now we have learned enough that's not too much of a problem, and so we are doing these surgeries as well. And to conclude, ladies and gentlemen, these are indeed extremely difficult times. Please understand that it is not easy for any of us. We understand that completely. The healthcare industry is trying to help. I agree there are some quarters, some sections of the healthcare industry which are compromising communication, which are overcharging and things like that. But don't believe that the whole of the healthcare system is like that. I do believe that a majority of people are doing a genuine effort, taking a genuine effort to help. This will continue for a long time, and so all of us have to understand each other. Calls for a lot of understanding, patience, and kind of patience is the thing that I really focus on. And we all have to develop emotional resilience. If you jump on a healthcare worker, that healthcare worker may jump back on you. So my appeal as a person who has been in practice for 35 years is to tell the people to be patient and to be understanding. And I keep telling myself, including myself and my team, to be understanding when somebody is shouting at them. It may be unfair, but we understand that that patient's relative or a patient is under tremendous stress. And so we do try to understand and not shout back. But the solution is for all of us to be as patient as possible. And as the Dalai Lama says, and I quote him several times, patience guards us against losing our presence of mind. Thank you very much, ladies and gentlemen, for your patient listening.